Thank you, everyone. It's nice to be here again. Nice to see everybody in person. I am going to talk about some of the things that are updates from musculoskeletal management and from our group here. And I hope to do as good a job as Katie did, staying on time, but I'm happy to be interrupted if necessary. I have minimal disclosures. I still sit on the advisory board for Ipsen Pharmaceuticals, but haven't done anything with them for a while. And for the things that we've published, many thanks to Hunter's Hope, who helped support that financially a few years ago. The first thing is bragging. We finally got our first article published, and in relationship to the things that people were talking about this morning, a little bit earlier when Anna was talking about educating the pediatricians, I think this is a good journal for people to think about as a possibility to spread information to the to pediatricians. It's the Pediatric and Adolescent Healthcare Journal. And we did have in December of last year and then in January of this year, 2 issues that were published specifically to talk about issues in leukodystrophies for the pediatricians. And there are many things, as everyone knows, that could be, that many more things that could be said that we didn't say. We actually are pulling together a 3rd issue that will include a little bit more information about emergencies and risks. And I think this is a journal that has a decent impact factor, but not a huge one. But it's one that pediatricians can read fairly quickly. So they may use it a little bit like a throwaway journal, but it doesn't matter if they're getting the information that that will help them to take care of their patients. The shout out to Paco Perez, who also has an article in, I think the one in December, right? That was about respiratory and pulmonary issues. So not a bad thing to have, or to at least know about when you're talking with your pediatric primary care colleagues. Today, I want to focus a little bit more on, because Anna asked me to talk about things that were a little bit different, or some updates about things that we've been looking at with regards to the musculoskeletal issues for patients who have leukodystrophies. And I want to talk a little bit about positioning and alignment today. And I can't help myself. I'm going to finish up by talking about tone management. It's one of my favorite things. So, but just talking about positioning and alignment, why does it matter? Well, first of all, it matters for function for in several different ways. And I think obviously there's a wide variety of the way in which children function. Some people tend to think about function as being the way that you can actually do what everybody else is doing, and that you're not functioning properly if you're not doing it that way. But in fact, positioning and alignment matters for children who aren't walking, for children who aren't necessarily using their hands in the same way that other people do, or who aren't necessarily feeding the same way. And some of this has to do with the fact that the way that our bodies are aligned are meant to be the way that they're used. And then what happens in the central or the core part of our bodies is that if that's aligned properly, it helps us better with overall balance. And then that balance and alignment also makes it so that there's preservation of the vital organs. So without having the space for the lungs to exist, or for the abdominal contents to be organized the way they're supposed to be, the organs don't have the same opportunity to work as well. And then another thing that happens with alignment, that for people who have lived this, you know that skin integrity is at risk when the limbs and the core are not aligned the way they're supposed to be. And then perhaps most important, maybe not, but certainly part of importance, is that positioning and alignment can be really important for patients' comfort. And I think we have to keep that in mind all the time, because we owe that to our patients and to their families. So today I want to focus a little bit more on the hip and hip subluxation or dislocation, which was on the list of things that bothered Hunter as he was getting older. And I think when you look at this film, there are a lot of people in the room who don't probably spend much time looking at hip films and looking at seeing what it looks like. But this is a really nice photograph of an X-ray that shows subluxation and near dislocation on one side, on this side, and a fairly well-placed hip on the opposite side. So it's an easy way to look to see in one picture the difference between the two sides. Now, the orthopedic surgeons and the radiologists know all the details about it and would have been the ones who were more likely to have put these lines in than me, as an example. But there are things, because of the way they've drawn the lines, that can tell us some quick information to see whether or not a patient is in trouble. So the thing that's the easiest for me to look at is the acetabular slope and the way the acetabulum, and especially the edge of the acetabulum, lines up with the femoral head. And this line is drawn right here. And what's supposed to happen, which is what's happening on the well-placed side, is that the edge of the acetabulum contains the vast majority of the femoral head, which is right here. On this side, you can see the edge of the acetabulum, when you draw the line down, isn't covering most of the femoral head, which is not good. That's exactly what you don't want to see. And that's when you need to involve specialists and your colleagues in orthopedics to help understand whether or not there's a problem and how it needs to be. There already is a problem, but how it needs to be managed. The other thing that's really important to the orthopedic surgeons, and it's a little bit, when I talk to them about it, I still feel like it's a little bit their secret, and I don't quite get it every time, but the yellow here is drawing what's called Shenton's line. And for those of you who have spent time talking to orthopedic surgeons, they love to talk about Shenton's line. Now, Shenton's line only counts if the X-ray is done properly and everything's lined up properly. So again, there's a little bit of voodoo, and if you've been doing this as long as I have, you'll know what it's about, sort of thing. But the idea is that you can draw from this foramen here an arc and follow its natural course and draw a line up the medial shaft of the femur and draw an arc there, and the two should meet. And that essentially happens here. If you draw this arc here and you draw this arc here, you can see that those two arcs would meet and form a continuous line. Whereas on the side where the dislocation is starting to happen, Shenton's line is broken. And it's just important to have a little bit of a sense, I think, of what the orthopedic surgeons are talking about in case they send back that information to you and you're the person who the parents trust and you're the person who's seeing the child with leukodystrophy fairly frequently and following that patient more often. So you need to know what they're talking about. And so what we care about is migration index, which says whether or not the femoral head is covered, and then the I don't know, somewhat ephemeral Shenton's line, but if you can draw it or not, but now you'll know what it is that they're talking about. So why does it matter? Well, for children who are walking, it matters, and for people who are walking, it matters that the hip is in place, because walking is meant to happen in a way that mimics the way a wheel turns, like a bicycle. And our pelvis is aligned with our hips and our femurs, so that when we walk, we displace as little as possible from the center, and we're moving more like a wheel than anything else. We don't move like wheels, but every time you change what happens with the alignment of the pelvis and the hips, you go further away from being able to move like a wheel, and therefore less efficient in terms of what you're doing. For patients who are walking, that may make more sense, that it would be important to keep the hips well aligned. But whether or not a hip is in place also matters for seating balance and for sitting balance, because as soon as a hip comes out, the pelvis tips and you can't sit up straight in the same way. That again can lead to the problems that we talked about. We talked about when the pelvis is off balance, sitting for a long time, for patients who are sitting for a long time, changes the pressure across the skin. And if you've sent patients to a seating specialist, they talk about pressure mapping. That's going to be very different whether or not the hip is in place. And then again, something that's critically important to think about is that dislocated and subluxed hips are often painful. Not all the time, not 100% of the time, but at least 40% of the time in the people who can talk about it, dislocated hips cause pain. We looked a little bit at people in medicine, and especially talking about evidence-based medicine, like to talk about data and looking at data. And this is a presentation of some data that I thought was interesting in terms of why should we be paying more attention. One of the quick papers at the AACPDM meeting, which is the American Academy of Cerebral Palsy and Developmental meeting in September. It's a meeting that happens every year. And in September of 2022, there was a quick presentation from an orthopedic group in Western Canada who said that based on the way their medical system is set up, that all the x-rays of children who have hips that are severely subluxed, so meaning they're headed towards dislocation and dislocated, are collected in a group so that the orthopedic surgeons can take a look at them and see what they need to do to be managing those patients. And they found when they reviewed the hips that they were looking at, that 17% of the patients who had severe subluxation and dislocation had neurodegenerative disease, and most of them had leukodystrophy. So the question that was raised by this presentation was, should we in orthopedics know something about leukodystrophies? And I thought, well, maybe that's a good idea. And at least people are starting to pay attention a little bit. And then we at CHOP looked at the data that we have collected from our clinic in trying to pay a little bit more attention to the hips and to what's happening at the hips and whether or not what we need to be doing about it. Looked at 394, so nearly 400 films of 141 patients to see what did those films show and what were we seeing. And the average migration percentage, when we looked at all the data put together, showed that for every single diagnosis that's followed in our clinic, the average migration percentage was greater than 30%. And 30% is where it's important, certainly if you have a static disease, in the management of hip dislocation in patients with cerebral palsy, for example, that's the point at which patients should be referred to an orthopedic surgeon. So what that's telling us is that at least for the patients who we chose to image, that for every single diagnosis that's followed in our clinic, and there are a lot of diagnoses that are followed, the average migration percentage is greater than 30%. That doesn't mean that every hip is out. It doesn't mean that every hip, that there aren't x-rays that show that the head of the femurs are well seated in the pelvis, or what we call reduced with regards to the hips. But it means that we should be paying attention, at least in my opinion. Subluxation and dislocation were overrepresented in our data in patients who have Aicardi-Gutierrez syndrome. And that could be because our data may overrepresent patients with Aicardi-Gutierrez. I'm not sure about that. But in the data that we have, subluxed and dislocated hips were overrepresented in that patient population. It is true in general that migration percentage is related to a combination of both function and tone. So the hips are more frequently well seated in patients who are still walking, and are more frequently more subluxed or more of a problem in patients who have really high tone. So I think that's important. And then the other thing that we looked at is not how many of our patients have actually seen orthopedic surgeons, but how often did intervention happen for these patients? And it was only in 12 patients. Only 12 of the patients who were in this cohort had any intervention from orthopedic surgeons. We didn't look yet at the reasons why, but I think, again, similar to the information that Katie was presenting, is if we're supposedly paying more attention to this, and then the outcome is that only 12 of these patients have intervention, what does that mean? Why would someone intervene? Why would someone not intervene? Where are we getting with these things? And again, are we paying enough attention, or certainly over time, have we paid enough attention to what's happening with the hips? One thing that I think is important for everybody in this room who treats patient with leukodystrophies to know is that there is a free app that is available for both Android and iPhones that's called the Hip Screen, and you don't have to prove you're in healthcare or anything like that. You can look it up. Anyone who wants to have it can have it. This is a tool that was developed for pediatricians or for non-orthopedic surgeons who take care of children. It was developed for children who have CP because, again, that was the group of patients they were looking at. but this is a tool that lets you take a picture of an x-ray of a hip and measure or screen with this tool to see whether or not there's uncovering of the femoral heads. And again, this will give you a number. The way the tool works is there's a bright red line when you get into the danger zone, and it will tell you when your impression of the film that you're looking at shows potential danger for the hips in this patient. And I think that's an important thing for people who are working with patients who have leukodystrophies to have, because then you can look at the film yourself. You don't have to rely on the radiologist reading of it. You don't have to find an orthopedic surgeon to look at the film. You can look at the film with this tool yourself. You're not saying one way or another whether there's a problem, but you are saying based on the way that you look at this film, you would like someone else to take a look at the patient. And I think that's a really important thing. The idea was for pediatricians to all have this so that primary care physicians or primary care providers would be able to look at films themselves without having to wait to get a patient in to see an orthopedic surgeon, without having to go through those next steps if everything on the film actually looked fine with using this tool. Again, it's not saying when you use this tool that you would tell a patient or a parent that the hips are definitely out, that definitely intervention needs to happen. It's just saying it's time to get some more help with what's going on with the patient. The other thing that the hip screen has on it, this tool, is for anybody who doesn't have fairly easy access to an orthopedic surgeon. And this may or may not be relevant to anybody in this room, but I think it's important to know is that based on the migration percentage and the way a patient functions compared to the GMFCS classification, which is a functional classification for patients who have cerebral palsy, it recommends the frequency with which the hips should be screened or studied. And I think that's also helpful. It's rare to say that a patient should have a new imaging study of the pelvis more frequently than once every 6 months. And for patients whose hips are looking fine, they're young, they're functioning well, because you can compare function to the GMFCS scale, which is on this tool. It lets you know whether or not you need to, when you would need to get another set of films in the event that you're not sending your patient to see somebody in orthopedics right now. So some of this I've already said, but the time to refer to an orthopedic surgeon is when the migration index is greater than 30%. And then again, if you're using the hip screen tool, that will be when you're in the danger zone, the red zone. It's also important to refer patients if the patient is in pain or if the rate of migration is increasing rapidly. And you can see this again by just using a screen. Why would someone intervene? Well, I think for all the reasons that it's important to follow this in the first place. And that would be if the patient's still walking, you want to intervene to see whether or not, or you would want to consider intervention if it might keep a patient walking, if it can help with sitting balance, if it can help with skin integrity, and then also if it's going to help with pain. And the pain is the trickiest thing. Because of timing and because of the need for timing and the inability to accurately predict the future. Are you going to operate on this kid? Yes or no? Well, for everybody who treats these patients, with leukodystrophies, you know that it's not just a routine thing. It's not a routine thing for any child to go into a major surgery, but it's also not routine for a child who has a leukodystrophy who has an increased risk associated with the use of anesthesia. And if you could say, well, it's not going to make a difference for walking. I understand from seating specialists that I can help with the sitting balance issue. The child isn't sitting independently anyway. And I know that there's a 60% chance that this hip is not going to be painful. Then what difference would it make to intervene? And I think that the issue is understanding a little bit the timing related to surgery. I was under the mistaken impression that surgery could happen anytime so that you could just wait to see. And if the patient were in pain, that then surgery could happen at that time and that it would relieve the pain and there was no more issue. So why jump the gun? But in fact, what happens to the acetabulum, which again is the socket here that's holding the hip, is that over time, and this is happens more rapidly in children who are younger and still developing, but the acetabulum needs the head of the femur to be there to help form. It also needs the head of the femur to be there to keep from degrading. And that's why when an orthopedic surgeon looks and says, if I'm going to fix this hip in a 6-year-old or a 10-year-old, it needs to happen within the next few years. It's because the acetabulum will degrade beyond the point at which it can truly be reconstructed successfully and make it worth the surgery. So that if you elect not to do it, and then at 15, the child is in horrible pain, the option to reconstruct the hip is no longer available. So not a good answer, right? You'd like to be able to say, I can predict the future and I know whether this is going to be necessary or not. But again, I think it's good to understand why you might get the information that you get. All right, so I promised I would come back to tone management. One of the things that we know that's important about the hips and the hip location is that hypertonia is will make it so that the hips are more likely to dislocate, especially in patients who are not walking. So I thought I'd review just a little bit what maybe some of what might be new or not well known with regards to tone management. Spoiler alert, most of it's the same. So there aren't really great new things. There's nobody coming out who's suddenly been able to manage all hypertonia for all patients in a way that keeps them from increased tone having a negative effect on the body. But to start with non-invasive sorts of things, there's been a lot of attention around vibration therapy. And this is something that's done usually in conjunction with physical therapists. There are a lot of commercially now available and medical equipment available that are vibrating plates that children are being urged to stand on. Some people are incorporating vibrating plates into standers for patients for them to be able to have vibration, with the idea that the vibration is going to reduce tone. And it does. The question about whether or not using vibration matters and is necessary to incorporate into the way a patient is treated, and or whether vibration will in fact change the need to use any sort of other intervention to manage hypertonia, is pretty clear that this is going to be an adjunct, but not helpful. Or not helpful as a replacement for any sort of medical management for hypertonia. There are mixed results in the studies that have been done that are really nice studies that have been done primarily in adults who have had strokes. And it is true that using a vibration plate will decrease tone in conjunction with stretching and in conjunction with lots of walking. But it isn't clear that long-term that there's any sustained benefit of the vibration that relates to function, or that relates to our ability to measure tone, which isn't great either, but our ability to measure tone and hypertonia in patients. The other thing, though, that I think is important is that fairly consistently patients report liking the vibration. Not everybody does, but lots and lots of people like it, and lots of children like it. So I think that when your patients are asking you, or their parents are asking you, is it time to get a vibrating plate? How many minutes a day should my child spend on it? I think it's helpful. It may make people more comfortable, but it's not a way to be able to say this is going to replace any other sort of tone management. And for people who are paying for some of these devices out of pocket, it's a fairly expensive device. I think it's important to understand what the help will be. Patients may feel better. That's great. They may like it. Their tone will go down some. But if you're deciding between that and next month's mortgage, pay the mortgage. So I think that's the information to date. With regards to medications, there are no new enteral medications that are on the market. There are anecdotal benefits that haven't been necessarily recorded in the past for using gabapentin, especially in patients who have primarily dystonia as their type of hypertonia, and lots of patients who are starting to respond to dopaminergics, although people have been using those for a long time, again, with variable success. And then recently in our clinic, we've had more success with clonazepam. I don't know if there's been a change in the water in Philadelphia and now people need clonazepam instead. But I think just thinking about those drugs in conjunction with other drugs that you might be using for tone management, like baclofen. Patients with leukodystrophies in general may be more sensitive to cognitive suppression with medications and may require a slower ramp up of using any of these meds than what's listed in the literature for treating patients who have hypertonia from a static lesion in the brain. No profiles have been published yet for any patients who have leukodystrophy with regards to baclofen metabolism. But for those, again, from listening to All Day yesterday, more and more things are being checked out with regards to genetics. And it is clear that baclofen is metabolized based on the ABCC9 gene, and there are 5 different levels of rates of metabolism. So that's something that you can check right now to see what's the ABCC9 gene in any of your patients when you send it. The cost of checking that is about the same cost as getting a combination of a CBC and a basic metabolic panel, so not particularly expensive. And then you can check with your clinical pharmacologist to see what's the implication of the genetics of your patients if you're looking to do this, to see how you might dose baclofen and especially how you might titrate it if you're hoping that will be successful for tone management for your patient. Intrathecal medications all work better than enteral medications in the tone management world. And the one that's used the most commonly is intrathecal baclofen. It's just important to know that. And then it's becoming, at least again in Pennsylvania, becoming much easier to prescribe 5 milligram baclofen tablets than it was when they first came out. And that makes it easier to be able to get a smaller dose. Suspensions are getting harder to prescribe, at least for us, and harder to guarantee that they're accurate, and that the suspensions stay accurate. The recommendations are to shake the medication, to keep a suspension refrigerated. I don't know about your clinics, but our clinics last all day, and we see people pulling out the suspension of baclofen from a backpack that wasn't refrigerated. So it's hard to maintain medication that way. And we really try very hard to get all of our patients using tablets rather than suspension. But again, that has to be how things are going in your area. We also have had fewer problems with patients being overdosed or underdosed when they're using tablets rather than suspension. Chemodenervation is essentially the same. Dysport has been out for a while. Xeomin, FDA approved in the more recent past. That's approved for use in the salivary glands, is dosed the same way that Botox is. Dysport tends to last a little bit longer. It does in all the studies, and it also does anecdotally in patients. New on the intramuscular neurolysis field, for those, some of you may have seen it, but now there's cryogenic neurolysis, which allows for better recovery of the nerve itself, because it doesn't permanently destroy the myelin sheath when that's being done. There is a physiatrist in Canada who's doing this more than anybody else. And for anyone who's interested in doing that, he's pretty available in terms of letting you come to his clinic and watch and see how he does things. Both of those and really good effective use of chemodenervation require localization with e-stim or ultrasound. And that gets to the need for cooperation of the patient. And I think this is a topic that comes up all the time. How do you best get your patient to cooperate with you when you need to localize and when you're doing injections? And there's an article that came out again in the CP journal talking about the importance of managing pain during procedures for children and the relative reluctance of injectors to use anesthetics for their patients when they're doing injecting. But it talked about that. Again, it's really important to know the relative risk for the patient when you're using it, and the expertise of the people who are providing the anesthesia, as well as the type of drugs that are being used and what the potential effect over the course of the day will be. I also think it's important for people to pay attention that some of our patients can stay relaxed fairly easily and not maybe give us a hard time, but for all of us to remember that there is going to be pain that's associated with these procedures. And then there's some attention now being given to the psychological tolerance of patients going through repeat injections for really just about anything. But if we're talking about that for tone management here. Surgeons can do neurectomies and focal neurectomies, and that can be helpful with tone management for some patients. But most of the surgical intervention for tone management is permanent, and it's important to remember that that may not be a good idea in someone with a degenerative disease. And then finally, back to function, because that's what we do in rehab, is put the fun in function. There is improved global function with treating the disease. So to those of you who are coming up with cures, please keep at it. I think that that's going to make the biggest difference. But another shout out for appropriate nutrition, because that can also be a key thing. A lot of our patients are starving if they're still trying to eat by mouth, and tone, function, and comfort improves with improved nutrition. And then finally, please pay attention to the hips, or think about them as being on the list. And thank you very much.